If that didn't impress you, I want you to know I happen to be the token American on the board of the Dix-Falusi Foundation, for your information. And I want to dedicate this presentation to the ex-president, Dr. George Bartfai, and the incoming president, Professor Tihomir Jovanovic. What I'm going to try and explain to you today, not quite as exotically as Professor Benejano, is that there are some underlying pathophysiologic mechanisms that we have not identified that cause heavy menstrual bleeding in women. And so I'm going to it says etiology and therapy, but the bottom line really is that I'm going to talk about the therapy and then the etiology. So I want to tell you I'm very impressed to be here with you today because we were here 8 years ago as part of the Dix-Falusi Foundation. And I must tell you the most impressive thing that I see in this building has nothing to do with the architecture, but it has to do with the mosaic on the wall behind me, which I think is the most intriguing piece of historical memorabilia that the Serbian people can have. And I think it's wonderful. So today, I'd like to introduce to you my collaborators over the last 8 to 10 years, 2 PhDs, Professor Diane Duffy and Terry Jacot, who are in the physiology department, 4 MDs who have either been a fellow or a faculty person at the Eastern Virginia Medical School. And the Eastern Virginia Medical School is located in Virginia. Washington is probably the best known city at the northern part of Virginia. But if you followed the recent problem in the Mideast, Norfolk, Virginia is home of the largest U.S. naval base and has deployed 2 carrier strike forces into the Eastern Mediterranean. The other members are Drs. Pakrashi, Sadik, Demirel, and Ramadan, who have contributed individually, emotionally, and physically to this presentation. So abnormal uterine bleeding is really a new terminology, and it was brought forward because we were getting involved with metrorrhagia and menorrhagia and metromenorrhagia, and we needed something clearly identifiable to say this is abnormal. So abnormal uterine bleeding came about, and abnormal bleeding, as described in this task force, has 2 components. It's either structural, shown on your right-hand side, polyps, adenomyosis, leiomyoma, or even malignancy. Or it could be non-structural, shown on the left, a coagulopathy, ovulatory dysfunction, endometrial in origin, iatrogenic, we have still no known cause and not yet classified. But if you look at it from a clinical perspective, 30% of United States women, and potentially in your country, have uterine fibroids, and by the age of 50, somewhere over 50% of women have evidence of uterine fibroids. 30% of visits to physicians for menstrual abnormalities have to do with heavy menstrual bleeding, and therefore it is obvious that there could be a sufficient overlap so that you begin to believe that all fibroids bleed, or all bleeding is fibroid related. And yet that is not really the case, because there have got to be a variety of mechanisms that are involved in the biology of menstruation that results in heavy menstrual bleeding. However, as a descriptor, in 1966, they analyzed the amount of menstrual blood loss using the alkaline hematinic method in a group of Swedish women, and found that when they lost more than 80 milliliters of blood in a menstrual period, they became anemic. And so they arbitrarily drew this line that a blood loss of over 80 milliliters was, again, heavy menstrual bleeding. On top of that, heavy menstrual bleeders have a duration of bleeding of 7 days. Why do they stop? This is an enigma that I still don't really know the answer to, but it's an obvious cause that this is a self-limiting disease. It is so self-limiting that you can ignore it until the next menstrual period when the woman is unable to go to work or doesn't leave home because she's afraid of soiling her clothes because of the bleeding that is so excessive, and she needs a local bathroom because the bleeding is unstoppable and comes out in a gushing-like fashion. It will occur in women between the ages of 30 to 35, and some women start with heavy menstrual bleeding, but this is an acquired disease. And so this combination of physician visits, uterine fibroids, and heavy menstrual bleeding has been a problem that we've been faced with for many years without a clear-cut single answer. And that failure to have a clear-cut single answer is shown here in the multiplicity of treatments that are available to you as a clinician to manage this disorder. Combination oral contraceptives will reduce menstrual bleeding in normal women and will also reduce menstrual bleeding in women with heavy menstrual bleeding. And several of them have specific Food and Drug Administration indications for this in their package insert. They're not approved for women with uterine fibroids. On top of that, when you're using, they create a reversible infertility in the woman. So if she's anxious to become pregnant, but anxious not to have all this menstrual bleeding, which interferes with her sexual function, treating her with a birth control pill is perhaps not the best way to go. Hormonal intrauterine devices, the levonorgestrel-releasing intrauterine device came on the market as an effective contraceptive, not requiring compliance, remembering the pill every day. It also was found to significantly impact the lining of the uterus and to reduce heavy menstrual bleeding. It again is not approved for use in fibroid-using women. Non-steroidal anti-inflammatory drugs, for some inexplicable reason, were shown many years ago to reduce excessive bleeding in a small percentage of the cases, somewhere between 20 to 40% of women. And in 2 presentations, 2 published articles, did not have an effect in women with uterine fibroids. Our current vogue is gonadotropin-releasing hormone agonist and antagonist. The problem with both of these treatment modalities is they create a menopausal condition, a hypoestrogenic condition, resulting in bone loss. And so gonadotropin-releasing hormone agonists, although they will prevent bleeding by inhibiting the pituitary-ovarian axis, they also reduce bone, and bone loss is prevalent, and the FDA only allows them to be used for 1 year before taking the women off. Tranexamic acid is a drug that has had a long-standing history, along with the ethamsalate as interfering with the bleeding with no known cause. If you place a copper intrauterine device into a woman, you will not interfere with her ovulation, but her menstrual bleeding will increase significantly, thought to be due to an inflammatory condition in the uterine lining, and relieved by the use of tranexamic acid. And I will come back to show you how that mechanism works. The gonadotropin-releasing hormone agonists are in play. Anything that is new from the pharmaceutical industry is new. I have a new dress, I have a new suit. Newness is uniqueness, and newness is exotic. And so the medications that are being used today inhibit the pituitary such that you get a relative deficiency of estrogen and an implication or an effect on ovarian follicular development. And all of them require additional therapy with estrogen and a progestin in order to keep bone from being lost in their condition. So this is what you have today on the open market. These are the drugs that do work or have been shown to work, GnRH antagonists. Estrogen plus progestin is added back. Combination birth control pills cause infertility. And the progesterone-reducing intrauterine device, effective, efficient, causing infertility. Tranexamic acid will reduce menstrual blood loss by 50% in 50% of the women with or without fibroids. And non-steroidal anti-inflammatory drugs will reduce the menstrual blood loss between 10 to 48% in women with no obvious cause, based on a Cochrane review. So now I'm going to switch from therapy and talk to you about etiology. Menstruation is a taboo subject. We don't talk about it at cocktail parties. Mothers don't talk to their daughters about it. Siblings don't talk to each other. And currently, maybe a friend will do that. Several years ago, I was in Saudi Arabia, and a gynecologist told me, I was talking on a subject, tranexamic acid, and told me about her 14-year-old daughter who became severely anemic with a hemoglobin of 7 before the daughter told her mother about how heavy her periods were. This was a gynecologist. Communication is very difficult for a taboo subject. At the same time, we have talked about metalloproteinases initiating menstruation because they are breaking down the protein ground substance that supports the endometrial tissue, as I will show you. And when that breakdown of the collagen support occurs, blood vessels break. And when the blood vessel breaks, it does like every blood vessel that is broken, it bleeds. What you know is that in order to stop that bleeding, you have to develop a clot. If you don't stop that clot from going forward, it will run right back up that vein or artery. So the body has a mechanism whereby plasmin degrades the thrombin in the clot and allows the clot to dissipate. And when that occurs, the vessel lumen is open and able to create new blood vessel growth, neoangiogenesis. So in women with heavy menstrual bleeding, in a clinical study published in 1988, they showed that there were intravascular clots present within 24 hours and up to 24 hours after the onset of bleeding in women with normal menses. In the uteri of women with heavy menstrual bleeding, they had fewer intravascular clots in these blood vessels. They had more holes in the clots, the fenestration, and they suggested that this was increased fibrinolysin. Now, why does fibrinolysin play an important role in menstruation? Menstrual blood has high levels of fibrinolytic activity. If it did not have this high level of fibrinolytic activity, the blood would clot, and that blood would never get out of the uterine cavity. So it has to be maintained in a liquid state in order to egress through the cervical canal. So the bleeding that you're seeing occurring is current because the upper functionalis layer of the endometrium, shown at the top of this slide, has broken down from hypoxia related to vascular vasospasm. Not in the capillaries, shown at the top, but in the arterioles, shown in the middle. And the upper 1/2 of the endometrium is sloughed at menstruation. Not totally. In an artificial environment with the rhesus macaque, only 50% of the endometrial functionalis is lost if you withdraw both estrogen and progestin. So that what is happening here is that these blood vessels in localized places in the endometrium are breaking down, and the endometrium is sloughing and the bleeding is occurring. And in hemostasis, the most important part of the hemostatic thing after vasoconstriction is platelet activation with von Willebrand factor, the laydown of fibrinogen, the creation of a platelet plug, and you block this vessel lumen. Now, you don't want it to stay blocked. You want it to open again. And now what you do is you now want to take away the fibrin that is formed and create a lysis so that the blood vessel can open up again. And the plasminogen activator system, which you may never have heard of before and you may never hear of again, is an important function that clears this clot from the blood vessel. Tissue plasminogen activator is present in the endothelial cell, and it stimulates the conversion of plasminogen to plasmin. And plasmin is the fibrinolytic factor that breaks down the fibrin formed by the thrombin and dissolves this blood clot. Plasminogen activator inhibitor 1 is the specific binder and inactivator of tissue plasminogen activator, and it also is known as SERPIN1 in the current vernacular. So in this diagram, what you see is, on your right, tissue plasminogen activator, TPA, is controlled by plasminogen activator inhibitor 1, but there is a relative excess of tissue plasminogen activator, and it stimulates plasminogen to plasmin, and the plasmin degrades the fibrin. Couldn't be simpler, maybe. There is an increased amount of both plasminogen activator activity, protein, the physical amount, and the plasminogen activator inhibitor 1 protein in menstrual endometrium and fluid in both normal women, but even more so in women with heavy menstrual bleeding. There is also one other factor that is common in women with heavy menstrual bleeding. There's an increase in COX-1 and COX-2 messenger RNA in the luteal phase. These are the cyclooxygenases that form arachidonic acid converted to prostaglandins. And it is more so in heavy menstrual bleeders. And there's an increase in prostaglandin, specifically E2. There's also been reported an increase in tumor necrosing factor alpha in the menstrual effluent. So the menstrual effluent, the menstrual blood, has two factors: more fibrinolytic activity in heavy menstrual bleeders, increasing amounts of prostaglandin, E2, and to some extent F2 alpha in the blood. Our hypothesis when we started on this was that prostaglandin E2 was increasing the tissue plasminogen activator more than the inhibitor, and this relative excess of tissue plasminogen activator was causing fibrin and causing the dissolution of the clot. So we felt this was what we were going to see. We were going to stimulate this endothelial cell with prostaglandin E2, tissue plasminogen activator would go up, plasminogen activator 1 would go up, and in the heavy menstrual bleeding, we were going to see more tissue plasminogen activator and no change in the plasminogen activator inhibitor. Hypotheses are meant to be destroyed. What we actually found, and these are results of prostaglandin E2 on tissue plasminogen activator and PAI1 in endothelial cells from women with normal menstrual bleeding, shown here. Tissue plasminogen activator did not change compared to control. If we looked at heavy menstrual bleeding, tissue plasminogen activator did not increase. If we looked at normal menstrual bleeding women, the plasminogen activator inhibitor, it went up instead. Essentially, you were binding more tissue plasminogen activator, and now you're keeping that clot integrity. But when you looked at the heavy menstrual bleeders, nothing happened to plasminogen activator inhibitor. It did not respond. That meant that everything that endothelial cell was putting out was tissue plasminogen activator. And this differential meant that there was more functionally active tissue plasminogen activator causing increased fibrinolysis. Shown here, normal menstrual women, we increased a little bit plasminogen activator inhibitor, but TPA remained unchanged, clot integrity maintained. In the heavy menstrual bleeding women, where we thought tissue plasminogen activator would go up, it did not. So this yellow error is an error Error, I'm sorry, it's the English. Serpin-1 was unchanged in this case, and bleeding occurred because of fibrinolysis. Show it here for you. In the arachidonic pathway to prostaglandin E2 in normal endometrial endothelial cells, you have an elevated PAI1, you have clot. In the heavy menstrual bleeders, you have no elevation in PAI1, you have increased fibrinolysin. In this situation, we believe that the most appropriate therapy is to use tranexamic acid, which occupies the plasminogen system's binding site for tissue plasminogen activator and keeps it from being converted to plasmin. And therefore, if we're looking for a specific technique, non-hormonal, this is the most apparent and obvious one. Our conclusions today, which could change tomorrow, are there are multiple medical treatments for heavy menstrual bleeding with variable response for the treatments. Our hypothesis is that the plasminogen activator system is dysfunctional in these heavy menstrual bleeders. The PAI1, also known as Serpin-1, did not respond to prostaglandin E2. The results indicate significant increase in fibrinolytic activity. Tranexamic acid blocks TPA, stimulated conversion of plasminogen to plasmin, and it's a more specific treatment for heavy menstrual bleeders. I thank you for being with me for this evening, and I hope you have a great night. Thank you.